Mr. Robinson is a gentleman who has had a contracture of his, progressive contracture of his ring finger now for, what'd you say, about 20?
About 20 years.
20 years, yeah. And we met recently in the office, and it's quite clear that what he has is an entity called Dupuytren's contracture, which was described by a Frenchman in the late 1800s, and nowadays we see this primarily in people of Northern European extraction, and the finger most commonly involved is the ring finger. And what happens with this particular disease is that the normal tissue in the palm, which is called palmar fascia, in some people with a particular genetic predisposition will begin to develop a thickening of that tissue, and the classic features are a longitudinal cord. Sometimes they'll develop nodules, which Mr. Robinson has here, and occasionally they'll also develop pitting of the skin. And over time, in some people, this process progresses so that they'll develop contractures of either the MP joints, which are the bigger knuckle joints, or also of the smaller joints called the proximal interphalangeal joints. Once the contracture progresses to the point where it's difficult for the patient to put their hand flat, and that usually equates to about a 30-degree contracture, or any degree of contracture in the smaller joints, it's at a point where it ought to be treated. And fairly recently, within the past 18 months, a new product has been introduced to the treatment armamentarium for this problem, which is called Xiaflex. It's a collagenase enzyme which can be injected into the cords to disrupt the cord and allow the contractures to improve. Now, it doesn't remove the tissue necessarily. It does dissolve in a very local way the cord, and that can allow us to manipulate the joint into better extension. The ideal indication for this is a cord in the palm, which causes a contracture of the MP joint. Now, Mr. Robinson has a contracture at this point of about 50 degrees at his MP joint, 55 degrees at his MP joint, and about 35 degrees at his proximal interphalangeal joint. So this is really an ideal indication. He's got a very well-defined palmar cord. It's very palpable. It's quite narrow. He's got good skin overlying the cord. And I think this is an ideal indication to try the Xiaflex collagenase. And the way we do this is to, under sterile conditions, we put an injection of this material right into the cord in 3 different locations, 3 different directions into that cord. And that is done without an anesthetic. We do it just with a small gauge needle, a little bit uncomfortable as it goes in. And then 24 hours later, we manipulate the joint. And usually at that point in time, if all goes well, the cord has been dissolved, and we can manipulate the joint and improve the extension, particularly of the MP joint. It is not uncommon that the patients require more than 1 injection to resolve all the contractures. The average number of injections per digit is about 2.7, so just under 3 average per finger to fully improve the alignment of the digit. Again, it's most appropriate, I think, for the patients with the MP joint contractures of this joint. A bit more difficult for the PIP joint, though he does have a nice, well-defined cord along this side of the ring finger out beyond that joint, which may be also good for a secondary injection. So today what we're going to do is just inject his palmar cord at this location today, and tomorrow we'll see him back and we'll manipulate the joint and hopefully improve his extension. What we do on the day of the procedure is we have a powder, or what's called lyophilized solution of the lyophilized material, which is the collagenase, and we have a sterile dilutional liquid, and we use a very small syringe and needle. And for the cords in the palm, we actually use exactly 0.39 milliliters of dilutional fluid, which we draw up in this syringe. And we mix that with the powder form of the Xiaflex collagenase. So with another syringe, we'll draw that up exactly 0.31 milliliters of this material. Okay, now we're going to inject the first third of this directly into the cord in a vertical direction. Hard to see perhaps, but now there'll be a little pin stick here, all right, Mr. Robinson?
Yep.
Okay, here we go. And that cord is really firm, really hard. And when we inject, it should feel, there should be considerable resistance on the needle when we inject, because it is, again, we're injecting into a very firm, hard material. So that's the first third of the injection right there. Then we withdraw the needle slightly and then redirect the needle at about a 45-degree angle, a little more proximal into the cord, and we inject the next third into that area. And then finally, we withdraw the needle and direct the final third at about a 45-degree angle, slightly distal. And again, there's a lot of firm resistance as we're injecting into this very dense connective tissue. Okay, and that's the injection. Now, what I do at this point is put a very simple dressing on. Often within the next few hours you may feel a little aching discomfort in this area. Some people experience a little swelling in the hand, in the palm as well as on the back of the hand. Because it is a protein that we're injecting, there sometimes is a bit of a biologic reaction to that, and some people will actually experience some swelling in the lymph nodes under the arm or on the inside of the elbow. That's not unexpected. That's pretty normal. So again, we just put a very simple dressing over that. Most patients don't need any pain medication. They don't need to worry too much about it doesn't interfere with their sleep. And they can use it if they feel comfortable using it for most normal activities.
No restrictions on...
No, no. I think you'll find that it'll be easier for you to just take it easy for the first for the next day. But again, the worst part of it is over. And then tomorrow when you come back, what we'll do is actually put in a what I call an intermetacarpal block. I'll put some Novocaine in here and here, which numbs up this area, and that allows me to manipulate the finger fairly vigorously, which you do need to do when you're trying to correct that and disrupt that cord. So again, over the next 24 hours, just do what you want, do what you can do comfortably. If it aches a little bit, just keep it elevated. Put a little ice on it, perhaps, for 20 minutes if it's uncomfortable. But I usually find that patients don't need any prescription pain medication or anything. And then again, tomorrow we'll see you back tomorrow afternoon, and we'll numb it up and then give it a manipulation, and hopefully it'll be significantly improved.
Hopefully that will be it.
Yeah, exactly.